Welcome, everybody, to the Disaster Response Collaborative Surge Capacity Focus session for our April session. We're glad that you came back. We're glad that you joined us for surge capacity, and we will continue where we left off last month. Before we do, I'd like to make sure we give our acknowledgement and disclaimer. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And the content presented today is that of the authors and does not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. For those of you who have been claiming CEs or CMEs, our process has changed just a tad bit, and the instructions are going to be at the end of the session slides today. You can also find the change on the website. Not a lot has changed. It's just a little tweak. Your previous CEs and CMEs will transfer. You just need to make an extra step. And again, the instructions are at the end of the slide deck. But everything else remains the same. You need to attend the entire live session to receive the credit. You need to ensure that you do the session evaluation at the end, and make sure that your name is on the session registration, so that if someone has forwarded you the session or forwarded you their registration, just make sure that you change your name on your picture on the screen. Again, we are really excited that you've joined us today. We're excited to have everybody here. The session is being recorded, so the recording and the slides will be posted online, hopefully in about a week. If you have any questions, go ahead and throw those into the chat or the Q&A. Again, CEs for physicians, nurses, social workers, and EMTs are available. And this slide will be at the end of the session. We're also offering MOC Part 4 for physicians if you're interested in that. Something new, we have a focus area web pages. They are live. So we've got this website. So if you go to the DRC website, and on the left-hand side, you can go to collaborative session pages, and it will take you to each individual session page. So please check that out. We've got resources, we've got timelines. The main thing about that, if you need to register for the session, for the individual focus area session, or the large collaborative session, that is where you're going to go. So you're going to find those links on the webpage. Few extra DRC updates. Again, our focus area web pages are live. We've got some of you who have done the virtual tabletop exercises. We hope you've enjoyed those. If you haven't done them, you've got them coming up. Don't forget that the trainings for the facilitators and evaluator, the next one is Thursday, so that's April 3rd. That's going to be the last live session. If you're not doing that and you still need to get that training in before the virtual tabletop exercise, there is a recording available. And the main thing is that you facilitators and evaluators, you need to make sure that you get that training in, so that Chris and David will send you the materials for that VTTX. Keep in mind, whether you're doing a virtual tabletop exercise or your own at your hospital's facility, keep in mind some of the things that you learn while you're in there. So your participants, is it everybody in the hospital? Who are your external hospital participants that came and joined you. What were your lessons learned? What were some of your gaps, your aha moments? Because we're going to be sending you a data collection survey in a few weeks. We want to hear more about it. We're going to be asking you to also present on some of these sessions, but as far as having the collaborative and really getting a sense of what everybody's doing, we're going to send out a very quick, short survey to collect all that data. Again, this is the facilitated VTTX process. One things I want to highlight, I just have facilitators and evaluators need to attend that training session. When you attend that training session, the VTTX materials will be emailed to you. Then you get to go and have fun and attend that VTTX, and then we'll send you that data collection survey. Speaking of surveys, the PDPAC has launched. So PDPAC, the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals. The main thing you need to know as a DRC, so as a children's hospital, this is huge. This is fantastic. We are coming together nationwide, all of the children's hospitals, not just the DRC participants, but more, all the non-DRC participants as a children's hospital will also be completing this survey. So we're going to really get a sense of where we are in disaster preparedness in the country. For you as DRC participants, it is also your environmental scan. So keep that in mind. The main reason, the main things and what we want to get from the PDPAC is to establish a baseline, not only for you as a hospital, but as a nation. We want to identify strengths and gaps, monitor the progress. So as you take this environmental scan now, we'll monitor your progress and see and help you improve on the plan, on your surge plan, but also you'll be able to see your other plans or your other domains as well. Triage, infection control, decontamination, evacuation. There's legal, there's behavioral health. It's all the 11 domains that are in that EIIC checklist. So how do you do it? You can use this QR code that will take you right to the registration page. So again, that PDPAC is considered the DRC's environmental scan. One person and any person from your hospital can register. So you can go either to the website down at the link is down at the bottom, and you can find out more information and register, or you can use this QR code and immediately register. Anybody can register. And what's going to happen is they're going to ask you who your emergency contact is. So your emergency management director, manager, so on, and they'll ask that contact, and then that person will actually receive the full PDPAC survey. Okay. Registration and the assessment will be open tomorrow through the end of May. Registration is actually already open, so you can go ahead and use this and register your hospital today. But the assessment will be open through the end of May. So doesn't seem like a lot of time. It's not. It's a big survey. It's a big assessment. So go ahead and register and get started, and that'll give you more time. One thing I will point out, when you, there are 11 domains, and you can assign different people from your hospital to different domains. Don't do it all yourself. If you register and you put your name as that emergency contact, don't put your name, or you don't have to. Just keep that in mind. You don't have to put your name on everything. Share the love. It'll help. And with that, I will hand it over to Amina Hussein to talk to us about, give us a little update on who's here with us. Dr. Hussein, can you unmute?
I think you need to unmute her, Julie.
Okay, much better. Thank you. Um, so thank you all for being here. It's really great to see a lot of familiar faces and this very important topic, our second of our focus topics for the surge capacity and capability section. Just a little reminder that we have a great diverse group of people here. We have people from all over the country, as you can see in this map, for spanning both coasts, and the shaded regions have multiple hospitals from that state. So you can kind of see where your state is and what other participants might be from nearby you. And it'd be great. We'd love when different folks from within this group collaborate with each other, which we were seeing quite a bit of last time as well. Next slide. And we have also diversity in our makeup. So we have a lot of clinicians between nurses and physicians. We also have emergency management, EMTs, administrators, pharmacists, respiratory therapists. So we come from all different walks of hospital life, and to have different ways that we can contribute. So really love that participation during our breakout sessions and collaboration, because I think seeing things from multiple points of view can only help our situation. Next slide. So for today's agenda, we are going to talk about the surge activation of a surge event. So the first few minutes of an event, and just from personal experience, you know, you can trial this and test this in your hospital like 12 times and find new ways that you can improve upon it. Really excited to have our speakers today. Next slide. And the objectives for the slide would be to understand the criticality of the first 30 minutes of a surge event. So the activation and the communication that goes along with the activation, and what procedures your organization can take to improve your communication and activation plan. Next slide. Without further ado, I'm going to hand it off to Dr. Marie Luzon, who is at the University of Michigan. Just a couple of words. She's been there forever. I'm not going to elaborate on forever, but she's held many leadership positions there. And just to name a couple: Division of Pediatric Emergency Medicine, Associate Chief of Clinical Officer for the Children's and Women's Hospital, Associate Chief of Staff, and Associate Chief of Emergency Management. I'm sure there's many more that I'm not listing there within her forever years. And then after that will be followed by Kristen Bond, who is a Penn Fellow graduating at the Children's Hospital in Michigan. So I'm going to hand it off to Marie. Thank you for coming and talking to us today about this.
Thank you so much, Amina. And thank you to the organizers, Julie, Anna Lynn, Amina, Liz Foster, so helpful in getting us up and running and prepared. I'm going to come at this because remember, this is a quality improvement collaborative that this is. This is an all learning, all sharing event. And I'm going to share some hard truths about some epiphanies I had a few years ago when I was involved in improving our plans about some gaps that we had. And Kirsten's going to bring us home with some fantastic real-time and current quality improvement that she did in her shop. So without further ado, I'm going to be scary. They're coming, and some are already here. When you have to think about, when you get that pit in your stomach because you hear the radio crackling as an ED clinician, or you're an emergency manager, or a nursing leader in your hospital, and you know you're going to have to come up with the caregivers at the bedside, that pit in the stomach shouldn't be there by itself. It should be, we should be training and sharing with our colleagues on the front lines how they can help to get started. And watch out for the walking wounded. I always say this when I talk about activation and surge, because often people have arrived already and you don't even know where they are. They're in the waiting room, having arrived by private vehicle untriaged. And so every organization, there's no one way to do this. So every organization has to kind of come up with something that is going to be their activation plan before the overwhelm begins. In the world of, when I started in this business, you know, decades ago, social media didn't crackle and tell about a thing happening out on the interstate highway with a pileup before EMS even was done assessing the scene. So you get information by these extremely disparate sources. Yes, I wish it was perfect that EMS activated us. We knew what to do exactly, but often EMS doesn't have the full story. We've all gotten some little bits of information where they're saying there are going to be 15 critically burned children from a house fire, and perhaps it's really only 3 and you only get 1 at your site. So you may not have all the information. And the last thing is, no one wants to be the one to call the ball and have it be wrong. Everybody is quite nervous about that. Next slide, please. And I think as big planners or preparedness folks, sometimes we don't think about this hygiene at the beginning. We're calling it in a sort of silly way the first 30, but that 30 minutes could be life-saving. We have to think about emphasizing the importance of planning for the first 30 after, especially a no notice. Any minutes are important. 5 minutes could be important for making sure that we have what we need. And socializing the need to identify all of these elements. And I'm going to share with you some resources and some ways to do that. Here's the sad thing. I wish, you know, when somebody's having anaphylactic shock, you kind of know you need to get some meds and some treatments for that patient. You know the standard of care. For this, there's no one size fits all. It is so frustrating because even discussing triggers, how many patients, who should call the ball? There's no standard for this either. Some people might say, well, whoever's there that is the highest ranking person, well, where? In the emergency department, in the ICU, in the operating room? Who should call that ball and fan out? And I put a little red lightning bolt on communication, because when I talk to incident commanders and other leaders in this space, they say that communication and the pathway and the fan out is one of the most problematic things they struggle with, both in exercises and in real events. And what about the modifications? What if it's a burn or it's a mass casualty that's either a shooter or a blunt trauma? Are there exposures where you need to set up the hazmat tent? What if you don't give that information to the decision maker? You have to be able to remember to get that information. Some organizations do a first alert, and then they position some key staff and assets, but then they get more information and then they can relax it down. Others do a full activation. And that's maybe why people are nervous to do a full activation. That's going to bring in security. It's going to bring in people from home. It's going to have a whole cascade of costs and people's time and anxiety, and may delay care of other people. So no one wants to do the bad thing and activate when you don't need to. And then this is so key. What about standing down, either concluding or canceling the response in the appropriate time and manner? Next slide, please. If you just think about those key issues, you'll have your first 30 minutes a little bit planned out. We want to start with a poll. Are you familiar with your organization's activation process and how communication is disseminated, i.e. the fan out plan? No blame, no shame. We probably want to go back and do that other poll first. Is that how we want to do it? Do we do the first poll first?
Sorry, Dr. Liz, on which I
There
have
are
to
2.
switch over. Yes,
Okay. Yeah, the first poll is yes or no
that's
question.
what I thought. This is the
I think the prior slide.
prior.
Yeah, it's just prior, because the 2 polls were right next to each other.
Mm-hmm. Is not letting me pull this up. That's
And
the
we do need to
issue.
get on poll everywhere.
Okay.
And so the next slide after that, and there's your yes or no poll. And thank you, Liz. I don't know why it keeps popping to the second one and won't let folks answer the first one. But it's a yes.
It's not letting it activate for some reason.
Okay. All right. So how about this question? Do you want to do the first one?
Totally up to you. If everybody will go to the link that Liz put in.
You should be able to see both questions.
You should be
And
able to answer that.
this is just a consciousness raising question. If you can say with utter accuracy that you know how this is activated and how the ball is called, you can go ahead and answer this. But let's go to the next one. It looks like the only the second question is live on Poll Everywhere. And this is the who. It can be different in different places. Who calls the ball to call the, whatever you call it in your center, the code D, the disaster fan out, the alert, etc. And you might be a person that's not on this list, and not sure, and I don't know is a perfectly valid answer. So folks want to answer that poll. I'm not sure if you can see any responses coming in, Julie.
So I'm going to switch really quick.
Okay,
So I apologize for the switching back and forth.
no problem.
But if we go here, we will be able to see the responses.
Excellent.
I can see your response.
And having kind of scrubbed the literature a bit, I can tell you there is no one great answer for this. If I wish there was one recipe, I'll talk about some great resources, but there's not one recipe for who calls the ball in an organization to do an activation. If you guys feel like our answers coming in, is the poll functioning?
Yes, the poll is functioning.
Okay. I'm excited to see what the crowdsourced best answer is.
You can't see that, can you? I'm having technical difficulty today. Please bear with me, everyone.
No problem.
There
Kirsten
are
and
the
I-
answers. How
Thank you. Kirsten and I do not have so many remarks that we're going to overwhelm the time, but look at this variety. I'm kind of stunned. This is great by the variety of folks. And if if I wouldn't have guessed that that it would array out like this, but and it's okay not to know. 16% of people said they didn't know. So this is great learning. This is great learning for us. So let's go on to the next slide. And this is exactly what we wanted to discuss, the variety of different plans that folks have, or possibly lack of a plan. That's the concerning part for us. And we'll discuss some other options. So I'm going to call back to some previous search focus sessions. I'm going to thank Anna Lynn for last month and the originator of this slide, Dr. Amina Hussein. This is actually a little bit of a checklist in a nutshell, where you think about initiation, resources, and communication. And next slide, please. I'm going to really focus on that left side, the criteria, who the decision maker is, and that chain of communication, and a little bit of resource sharing around that. And the real deal of somebody who lived this and made it happen up and down their institution, Kirsten Bond, will come in after me and discuss the how that she lifted everybody's boats in her institution with her project. Next slide, please. I got to tell you, the checklist is right there for us in our Asper Tracy compendiums. If you look up hospital mass casualty response plan considerations, this is where those planning resources are. Beautiful set of checklists that focuses your mind in your organization about the authorities and declaration. And question 1 is broken out. Who has the authority? What are some sources of information? What do you need to know when you are going to invoke this? What are your triggers and thresholds? What's the process for initiating the response? This is a pretty rich resource. Next slide, please. And it goes on to discuss not just the alerting and mobilization, it's got templates and checklists, but discusses security, patient flow, registration, and kind of all the features of an MCI. But the discussion about communication management, which, as I said before, most experts are exceedingly concerned about, because that's where the missteps happen. That's a common deficit, and that discussion about that communication fan out and management is discussed in these resources. Next slide, please. And complementing those Asper Tracy resources, less than a year ago, last September, EMSC's checklist was refreshed. They have the disaster checklist, which I hope you're all very familiar with, and there is the URL for that. This is very inclusive of hospitals at the beginning of their disaster preparedness journey, who are kind of in the middle, and then advanced because perhaps they're a tertiary care children's hospital. But these checklists discuss the surge plans, and combining the MSC checklist and some of the Asper materials is probably the best compilation of preparedness for activation and communication that I have seen. You can share other hospitals' guidance, but this really gets you, EMSC and Asper Tracy get you to some checklists that I think would be great to start that activation revision, or if you haven't even done one, an activation planning for your organization. Next slide, please. I'm going to talk about my experience, and then I'll give over to Kirsten. So several years ago in my organization, we noticed that it was concerning to us that we weren't exactly sure how to start the ball rolling. If EMS calls and said we have a bus accident and we think we at least have 17 or 18 kids bad hurt, and there's some special needs kids on the bus with, that are wheelchair bound that came loose during the accident. If we got all that information and we were overwhelmed, who do I call? How do I know? What do I know to get stuff? So we created a one-pager. It is in the disaster binder and on the EHR to be printed. The person in charge is the charge nurse. You don't get to be a charge nurse unless you know how to activate this tool. And you pair with your lead attending. You know exactly who that person is in the emergency department if you're getting information, and you are asked to, how many victims? What are their ages? If you have that, what are the what do you have special needs? Is this a burn? Is this a chemical release? Is this a radiation accident? And then the rest of the S's, space, staff, stuff, systems, is put together for you by that decider, and in our institution happens to be the administrator on call. They will call you back very rapidly. You've gathered up the information with your charge nurse in concert, and your recommendation and data that you've gathered very quickly. This is a one-pager. Who, what, where, when. Do you have special needs? And what do you, how long do you think you have before the first victim arrives, or et cetera? Then the burden of the rest of the communication is taken away. That was our reason for initiating this. Your disaster cards, your call-ins, your security management, your standing up incident command, the AOC and the ICOC, the incident commander on call, assist you by letting you do your job as an emergency department, setting up triage areas, making sure you receive patients, making sure all the ancillary services are called. That is what we chose to do. That's how we do it. We have both the adult and pediatric emergency areas are very intertwined, although they're far apart in different buildings, in different hospitals. They're intertwined in knowing that they may receive victims. I may receive adult victims. They may receive child victims. So that's how we chose to organize it. It is something that we teach, or we at least try to. This is the hard part, training and teaching every attending and every charge nurse has to know how to do this. Do we fall down sometimes? I think we do. And my colleagues and I work on that. But you have to have some system. And it has to be known to your emergency management folks, to your incident commanders, your administrators on call. They know how this works. And this worked for us. I'm sharing it with you. And I would like to give over to Dr. Kirsten Bond from Detroit Children's Hospital, who has done a very tireless, major uplift of her system's readiness for a QI project that she's worked on as a PPN scholar. And she will describe to you how she created a tool, how she iterated it, and has uplifted not just her emergency department, but her whole organization. So off to you, Kirsten. I think Kirsten's still muted.
I'm awful with technology. So thank you, Dr. Lozan. Like Dr. Lozan mentioned, my name's Kirsten Bond. I'm awful with technology, and I'm a pediatric emergency medicine fellow at Children's Hospital of Michigan. And I wanted to share with everyone just one way that our hospital plans for MCIs, or sudden onset surge events. So at Children's Hospital of Michigan, when we were doing our large scale disaster drills where we bring in all of the students, it's a couple hours long, we recognized a big gap in our preparedness, particularly during the first critical 10 to 15 minutes of activation. And we wanted a way to enhance our hospital's surge response without requiring a ton of time or resources. So we actually developed this concept of the disaster roll call, which is a novel, low resource drill that's designed to improve early response efficiency. It's essentially a no notice in situ drill that's only about 10 to 15 minutes long, just to practice the first few steps of your hospital's activation response. Now, I'm going to share some of our data on the next few slides, not because I think you need to know all of the little details, but I really want to show you how this worked for us and our institution, with the intention of you sort of bringing it back to your hospital as potentially a tool that you can use. Next slide, please. So when we did this project, we divided it into two different phases. During phase one, we just focused on the emergency department. So we started small, just with our, own team. We actually did 7 ED specific just activation drills over 6 months, and they were about 10 minutes to complete. We came up with a list specific to our hospital of 11 initial steps that we felt were necessary for the successful activation of our disaster protocols. And throughout the project, throughout every activation drill, we tracked completion of those critical tasks. The goal here was really to practice the first 10 to 15 minutes of disaster response, focusing just on those critical tasks like role assignment, establishing communication, and other things like grabbing our disaster cart, our disaster supplies. We really wanted to drill this and make these sort of critical tasks muscle memory for people, so that if this were to happen in real life, no one would get that deer in the headlights sort of initial panic. Everyone could just fall back onto their muscle memory and know, hey, this is happening. I may not know how this is going to play out over the next several hours, but I know the initial steps I need to take. And the goal is for everyone to know those initial few steps. And what we saw was really awesome, in my opinion. All of our drills, our staff had a 91% more, percent or more critical task completion rate. And the time for all of these drills in phase 1 was under 15 minutes. So we kept them pretty quick. Next slide, please. Now, phase 2 is where it really gets cool. So we expanded this to include the entire hospital. So we reached out to our C-suite and we actually got really good buy-in from them. They approved us to do these drills every other month for a full year. And we were allowed to treat them as if they were a real drill or a real event. So we actually announced them overhead, like throughout our entire hospital. And then we at our hospital have this tenant alert system, which sends like texts, it sends phone calls, it sends pages. So every drill that we did, we actually activated that as well to test our hospital-wide emergency response notification system. Every department in the hospital was instructed by leadership to respond as if this were a real event and to practice their first 15 minutes. And this was everyone. So this just wasn't like our ED staff, like our surgery team, our anesthesia team, but it went all the way down to like security, EVS, and even our hospital clerks responded as if this were a real event. So for the project, we tracked 8 key departments because honestly, there are so many people that we got engaged. It was just difficult to track everyone. But we tracked 8 key departments like anesthesia, surgery, inpatient nursing, and our response rates were really great. Departmental participation was around 87% for all of those key departments. And the time to critical task completion was actually improved in phase 2. I will say that in phase 2, it did take a little bit longer because we had more people. In my opinion, we had more people that were responding. So I think that definitely contributed to the increase in time. Our average time was around 12 minutes, but we were still under that 15-minute goal. Next slide, please. So when we scaled up from the ED to the entire hospital, we saw some clear improvements. And I think a lot of that is because the ED felt very confident sort of leading this response, and the ED felt very, very comfortable because we had drilled this so many times. We saw a significant reduction in time needed for critical tasks like time to announce the drill, role assignments became faster, and retrieving essential equipment was much more efficient. Overall, we improved our time to readiness by about 25%. And the key takeaway here is that by practicing these specific early tasks repeatedly, we not only improved speed, but consistency across the departments. Next slide, please. And of course, with any QI project, we didn't just measure efficiency, but we also collected some qualitative data as well. So we had just a little bit more details. We had study observers sort of watching this and checking off all the critical tasks to make sure everything got done. We also had our study observers sort of look at how the overall drill went, and we had them rate things like leadership, communication, and just overall organization. And from phase 1 to phase 2, everything went up, which was awesome. We also sort of built in a feedback loop where after each drill, we would debrief, and any feedback that was given, we would make immediate adjustments. And that really helped sustain some engagement among all of the participating departments and our C-suite. Next slide, please. So just to recap, Disaster Roll Call, it's a novel tool that our hospital developed to really practice that first 10 to 15 minutes of disaster activation. They're really quick. They require limited resources. You can do them any time of day or night. We did these middle of the night, at midnight, 6 a.m., all sorts of shift times throughout the day. They're quick, they're easy, they really don't require many resources. And they're scalable. If you want to just do it in one department or with one group, you can do it with them, or you can scale it up as big as you want and include the entire hospital. And that is all I have for you guys. Thank you so much for letting me share that with you, and I'm happy to answer any questions here or offline if anyone has them.
Erica has a question in the chat that you might want to check on.
Um, Yeah, so what system are you using for the disaster roll call? So for this project specifically, so the disaster roll call is essentially just what we're calling like the mini drills, like the 15-minute activation drills. So when we page it out overhead, we are paging it out like overhead through our hospital and then also an electronic system as well. And then when we're just observing them, like for critical task initiation, that's just like we're doing it on paper, just observing them. I don't know if that specifically answers the question, or Erica, if you want to clarify it all, I'm happy to dive a little deeper. Perfect. And I will say that I saw Dr. Lozan had commented, sounds like C-suite buy-in as the first ask is a good idea. I think that one thing that really helped with our institution is we sort of marketed this as like a quick, low resource way to improve our readiness. So instead of like full drills where it would remove staff from their normal tasks for like hours at a time potentially and interrupt patient care, these would be like quick ways to help those frontline workers establish muscle memory when it comes to readiness. And Erica has a couple more questions. So how were you able to get buy-in from the surgeons to test this while they were in the OR? Were they expected to respond electronically or in person? So during the day, we have like every department has their own protocol for who they send down to the ER when one of these incidents occurs, or like in the middle of the night when we tested this at like midnight or 6 a.m. 6 a.m. the surgeons are there, but midnight they were not all there. They would essentially notify us and say, these are the people that are in house right now. The people that were in house would come down to our ER and check in. And then they would let us know, like, we would be here within X number of minutes. We also got buy-in from, like I said, every department. So like OR staff, anesthesia would let us know how many ORs they would have available, how many anesthesia attendings that they had ready to come in to open ORs, that sort of thing. And then let me see, did you get any feedback about testing these overnight? Yeah, so I didn't personally receive feedback about people being woken up in the middle of the night. I will say it was a little bit more difficult with ER staff overnight, particularly when we did it on, we had planned these well in advance with our small group team. So we actually had like some of our nursing admins, some of our ER docs come in at midnight when they weren't scheduled to be working to run this drill just for 15 minutes, which was awesome. And with limited staff overnight, I do think there was initially some pushback, but as we continued to do these, I think people, there was buy-in over time, particularly in our department. And then once we started doing them hospital-wide, I think the ER sort of, in my opinion, took a little bit of pride because we were sort of leading this for the rest of the hospital. Stu had asked, do you have a checklist of critical tasks? We came up with a list of 11 critical tasks specifically for our hospital. I'm happy to share that, but what I would really say is important is if you are doing something like this at your hospital, like Dr. Lozan was saying, every shop is different. Everyone is going to have a different sort of initial steps in activation. So for us, we had like part of our initial few steps, like One of them is we assign someone to specifically call blood bank to notify them of the event, the number of victims, etc., which may not be something that every hospital does. So what I would say is determine sort of what are your critical tasks that you need to do in the first 10 to 15 minutes and drill those things. And actually what we've seen on our last like full scale drill is all of our departments have essentially become so efficient in the first 10 to 15 minutes that we have in a way like minimized the need for incident command during those first 10 to 15 minutes because everyone just knows exactly what they have to do.
Okay. I think that we've had a pause on questions. Thank you we really love that engagement and, the experiential information, Kristen, that you're sharing, I think is appreciated because a lot of us struggle with some of the buy-in that everyone's alluding to here. And Marie, from your kind of years of experience and giving those important pieces that it really is hospital dependent and that we have to make it our own. We're going to move on and can you go to the next slide, Julie? We're going to go on to our breakout sessions where we're really excited to have everyone, if you're able to come off of camera, but just if you can't, then we understand, but participate and give your kind of experience of what happens at your institute. We'll break out into sessions now and then we'll come back and do a quick debrief before we move forward. How many groups do we have?
We have 5 groups.
Okay. I'm group 1, so I'm going to start with group 2 to just give us a call out on, innovative ideas or challenges that people are facing or, major points that were made that I think are helpful. So group 2.
So I was facilitating group 2 with the help of Erica Poposky, who was in the middle of saying something brilliant in the middle when we got called back to the large group. But please, Erica, add in anything that I do not, and that goes for the rest of the group as well. So I think the big takeaway that our group was talking about, and I think there was a lot of concurrence, was that these mini drills and the smaller drills are actually extremely effective and a lot easier to do just because they're short and they don't take as many resources and they actually can really move the needle in terms of education as well. I think one of our members was struggling because of the constant revamping of the plans, especially associated with renovations and in a facility, which I think many of us have also dealt with because it requires constant revamping of the plan, but then also constant re-education. And then I think engaging beyond the emergency department was also something that we were starting to discuss. And Erica was talking about how she actually has done is creating a hospital-wide committee for MCI. That actually is co-led by a surgeon so that you're engaging people outside of the ED and hopefully able to move the needle forward in that aspect. Okay.
Great. Thank you for that. Group 3.
That was me, Deanna and Kirsten. We were in group 3. So we had a good discussion that talked about, I'll just say, like, how do you identify people's roles when they show up in a room? So somebody talked about using vests. Another person had an innovative idea that talked about using surgical caps, and then they put the name tags on top of the caps and everybody wore those. So you could see them visually, like, this is the surgeon, this is a resident, this is, respiratory therapy, so on. So some people were working on a concept of reverse triage and looking at how that could be done quickly, especially in an ED or depending on the units, things like that. Somebody else actually mentioned that because of their co-location to a mass gathering site for their hospital, that like the lobby of the hospital is the most obvious place where people would go because it's kind of like right there. So how would you organize a mass group of people that suddenly start to present to, you know, not your emergency department because they're just going to the closest place that, you know, is sort of a ways from there. So I thought those were some really interesting ideas about, you know, how people were thinking about doing it. And we were just getting into a conversation talking about how does when the incident is actually notified to the hospital, the ED or whoever, who has that authority to sort of escalate it up the chain or to make the decision? And it just depends on where you're at. So it's like every institution. And as we talked about, is that, you know, it's really important to understand, you know, does the charge nurse in ED have the ability to make that decision, or is that something that has to be escalated up the chain of command before the decision can be made? So, yeah.
Wow, interesting ideas. Lobby as a shelter. We'll talk about that more when we do our space focus group. Number 4.
Hi, that's me. Similar to what's been stated before, the group did feel that a lot of the mini exercises that Kirsten talked about would be really effective as a way to test some of this. And again, I think kind of what Deanna was saying is that there was the challenge identified that oftentimes the group wished that somebody would just make the decision to call it an MCI. There was a lot of faith that the staff knew what to do once they got to that point, but sometimes it was briefing and rebriefing up and down the chain into the C-suite and this person before that decision was actually made. So, you know, empowering different people to maybe be able to make that call, because you can always, you know, dial that back after you make the call, but you're going to be starting from a behind position if you wait too long. And then other than that, we talked about some of the communication mechanisms in our group for like alerting staff and testing that. So we had some really great conversation, and I think the group is interested in a lot of those drills and kind of tabletop activities.
Great. Thank you, Liz. Group 5.
I was in group 5, fascinating discussion. 3 of the group members were from the same institution and really shared very generously their experience with thinking through, and we're a little bit ED focused here in this collaborative. We have a lot of PEM doctors, and sometimes we need to think about the other parts of the hospital, which both Kirsten emphasized engaging everybody. And this group really did a lot of self-reflection on areas like PICU evacuation, realizing that PICU evacuation would be a horrific disaster, whether even if it was just moving to the other smoke compartment and not necessarily a full, you know, extrication to the next floor or outside. So this is where we remember that we are not just, I know one of my team members from my hospital who is the trauma coordinator is on this call. And we sometimes forget that there are other people that are maybe involved that doesn't even involve the emergency department. There might be the NICU, the PICU. There's a fire up in the OR, and you know, that might involve, you know, 40 OR rooms that have to be managed, evacuated to the PACU. The entire hospital would have to be aware of what to do in that situation. And it's not just the ED. So that was a call out in my group to remember that other parts may be the initiator of a COD or a disaster. And they would need that sort of knowledge too. And I can't, in my heart of hearts, I cannot say if every individual unit, the way Kirsten's trying to have in her hospital, would know who to call or what to do in that first 15 minutes. If, for example, it was a NICU evacuation. And that's some work that we have to do. So I was really appreciative of calling out, let's not just think about how the ED would work or how an outside disaster would work, but an internal disaster of either loss of, power or a fire or an evacuation need in one of your critical units in your children's hospital. So thank you for that, Group 5.
Thank you, Marie. I think, yeah, involving everyone is key. And I'll end with Group 1. So we had some really amazing conversations. New Mexico, somebody from New Mexico was calling out how they had their recent MCI with a mass shooting, and how they, there was a little bit back and forth with activate and then deactivate and activate, but that, there is a difference between MCI that has blunt force trauma and MCI that has penetrating trauma, and recognizing if you're having criteria that might need to be different based on the incident that you're dealing with. Also, seeing that we have some people who are just kind of, learning their plans and trying to figure out where they're at and trying to figure out the best way to develop and to test those plans. And, definitely those short, small drills, or even starting with tabletops might be the most effective, but making sure to include all of your stakeholders. And then lastly, a really amazing system that they use in Missouri, and I hope I'm getting the state right, where there is one person who makes a decision instead of having multiple people who can make the decision, and there being some crosstalk and confusion. And that one person has a sheet that has some criteria, and it's like, if you hit 3 of these items, then you activate. If you hit 4 or 5 or 6 of these items, then you consider activation. So it's very nicely lined out for them, so that there is no, oh, you shouldn't have it hit these criteria or it didn't. And then also on that same 1-page sheet, there's all of the different notifications that need to happen. It's like a cheat sheet of the things that would have to happen for that person making that call at that moment, who's there 24/7. No, so really, really great systems, it sounds like, that are there that hopefully we can bring more to you going forward. Okay, I'm going to turn it back over to Julie. Do we have one more poll? Yeah.
Got one more poll if you want to.
And I think you have a QR code in the corner that we can also access.
So if you still have this up on your phone or screen from before, it should just move right in. Now, should being the key word on all of this, but it's the same. Okay.
Seeing a lot of communication here. I'm looking at all the different people that are involved, the spaces. Great. Buy-in. Okay. We'll let you guys keep on putting stuff in. With 1 minute left, we can kind of call out what people had written in here at the next meeting. I'm going to let Julie just give us a little bit of forewarning about what's going to happen next month.
Thank you, Dr. Hussein. So next month, we're going to all come together. So evacuation, triage, infection control, decontamination, our wonderful surge capacity group, and then reunification, our fourth session to our fourth focus area, will all come together for a full collaborative session. So that goes back to 1 o'clock to 2:30 Central Time. The registration code, I'm going to, I can put that in the chat, and you've also got this QR code. And that will give you registration for the full collaborative sessions through the remainder of the collaborative. So through next June of 2026. I can't do that for the individual focus area sessions. I'll have to do those 2 at a time. So for June 3rd and July 1st, we'll come back to the surge capacity and meet from 1 o'clock to 2:15 Central Time. And I will have those registration links sent out very, very, very soon. And yes, they will all be recorded and posted to the website. So for those of you who want continuing education, here are the instructions. Again, it's very similar. It's just a slight deviation. There's a single sign-on for a lot of people, all things PPN. So you'll go to the CE Peds Pandemic Network, log in, and you will select the PPN sign-in option. And so that's the different piece. So the instructions are here. You can also text that code, but either way, just know that you're going to need to put that code in either to the website or the text to get the CEs. So your session evaluation, you don't need to stay on for this. So if you need to get going, you can go ahead and put that use the QR code, or use the link that I just put in the chat, and then you can go ahead and log off if you need to go to another session. So we used Zoom poll before, and it just pulled up the evaluation. This allows you to do it later if you need to do the session evaluation later. So, but the link that I just put in and this QR code on the screen now will give you your session evaluation. So I hope to see everybody on May 6th. If you have any questions, you can always email dncppn@austin.utexas.edu. We'll put that in the chat as well. Thank you all for joining us today.